Yeah, trendsetter, whoa, league of my own, it don't get better. No, read what I wrote, I'm a bestseller. Yeah, reach for my goals, hit it dead center, hit it dead center. Bullseye, hit it the most, is no misses. Something like fish in a barrel, it's no different. Blindfold on me, I still got the most vision. Trendsetter, total.
Hello and good evening to everyone today. We are delighted to have you all join us for today's webinar, organized by Drools in association with the Indian Association of Veterinary Dermatologists. My name is Dr. Ivanka Fernandez and I'm from the Drools team. Before we get started, a quick note to everyone present. Kindly take a moment to fill out a form, a Google link that I have pasted in the chat box. If you fill it, you will receive your certificates in a correct name and format. So requesting everyone to, in the chat box, I have pasted a Google link to kindly use that to fill in your details so that we may issue certificates for the same. I would like to now invite Dr. D. Sumati, the Vice President of the IAVD, to deliver the welcome address.
Good evening. I welcome each and every one of you on behalf of Association for Veterinary Dermatology India and our knowledge partner Drools to this webinar. We are conducting a series of webinars on dermatology for the benefit of practicing veterinarians every month. Coming to today's topic, Cushing Syndrome in dogs. It is commonly seen in general practice where diagnosis and treatment can greatly improve the quality of your patient's life. In this free webinar, join Dr. K. Mohanambal as she walks through the Cushing's disease. She'll be covering what to see in your patient, how to diagnose or differentiate PDH and ADH, treat appropriately, and also on its management. Over to Jules for the speaker introduction.
Thank you, Dr. Sumati. Now it is time for us to introduce our esteemed speaker, Dr. Mohanambal K. She is an assistant professor in the Department of Veterinary Clinical Medicine at the Veterinary College and Research Institute Namakkal under Tanuvas, Chennai. A distinguished academic, she holds a BVSc, an MVSc, and a PhD in veterinary medicine. With an expertise in canine dermatology, she has been dedicated to pet and large animal practice since 2015. A prolific researcher and an award-winning author, she actively contributes to veterinary journals, student mentorship, and animal welfare initiatives, aspiring to make a lasting impact on veterinary dermatology. Thank you so much, Dr. K. Mohanambal, for joining and agreeing to speak with us today. Thank you. I would now like to hand it over to Dr. K. Mohanambal for her expert insight.
Good evening to one and all present here. I am here to share my expertise on Cushing syndrome in dogs. It is important to know, diagnose Cushing syndrome and how to spot and treat the same. So first, how the word Cushing disease coined, it is because of the Harvey Cushing's. He identified the disease in the year 1932. After that, hyperadrenocortisolism, also termed as Cushing's disease. It is a common endocrine disorder after hypothyroidism. We all know hypothyroidism is very important and very common endocrine disorder. After hypothyroidism, Cushing is the second most common endocrine disorder in dogs. It is because of chronically increased circulatory glucocorticoid It is observed in the general canine population at the level of 0.1%. That is, 1 in 1,000 dogs will have Cushing's disease. And this Cushing's disease will affect most commonly in female dogs than male dogs, as per the records. And middle to older age dogs, this disease is very common. The age is concerned 7 to 12 years, most common in the dogs of the age group of 10 years old. What is the physiology behind the cortisol production? From the hypothalamus, gonadotropin releasing hormone is produced, which stimulate the pituitary gland to release ACTH hormone, which in turn stimulates the adrenal gland to produce cortisol. So whenever systemically cortisol level reached normal level, which will give negative feedback to the hypothalamus, which in turn stop the production of CRH and in turn ACTH from the pituitary gland. So like this, the cortisol level is maintained in the animal body. Hyperadrenocortism is concerned. There is a spontaneous hyperadrenocortism and iatrogenic hyperadrenocortism. This is the most common types of hyperadrenocortism. So spontaneous is concerned. There are two types. One is pituitary dependent Cushing's disease and adrenal dependent Cushing's disease. Pituitary dependent Cushing's disease is most commonly encountered in most of the dogs, that is 80 to 85% of the general canine population. And it is because of the adenomas happening on the pituitary gland. The adenomas may be of microadenomas or macroadenomas. Microadenomas are most common cause of pituitary dependent Cushing's disease. This PDH will affect medium and smaller breed dogs, especially poodles, dachshund, beagles, terrier, boxer, cocker spaniel, and GSTs are highly prone to PDH. Whereas ADH is concerned, it affects only 15 to 20% of the canine population, and it is because of the adrenal tumor. PDH is not because of tumor, it is because of adenomas, mostly micro and macro adenomas. But ADH is concerned, it is mainly because of adrenal gland tumor. The tumor is of either unilateral or bilateral. That is, the tumor will affect either one single adrenal gland or it will affect both the adrenal glands. ADH is very common in large as well as some of the small dogs. Labradors, GSD, poodles and terriers are highly prone for adrenal gland tumors. Iatrogenic Cushing's, we all very know, it is because of external supplementation of the cortisol or steroids like prednisolone mainly and dexamethasone because of some other conditions. The iatrogenic Cushing's will affect any breed. We have recorded iatrogenic Cushing's especially in Labradors, Golden Retrievers, German Shepherds, and Bulldogs. Apart from this common type of Cushing's disease, we can also see ectopic tumors and food-dependent Cushing's disease. It is very rare. Ectopic tumors is because of bronchogenic carcinomas of lungs and pancreatic tumors and neuroendocrine tumors, which will stimulate or secrete the external ACTH. So instead of pituitary gland, these tumors will secrete the ACTH, which in turn increases the cortisol production from the adrenal gland. And next one is food-dependent Cushing's. Once the food is taken up, because of insulin dependence, ACTH should not be released. But in this case, ACTH is released after food intake, which in turn causes food-dependent Cushing's disease. These are all the major type of Cushing's disease in dogs. So this is the mechanism of pituitary-dependent Cushing's disease. It is very important to understand, even to diagnose the disease ultrasonographically. So please see this. If pituitary gland is affected, either because of microadenomas or rarely because of macroadenomas, it will secrete ACTH continuously. So it will stimulate both the adrenal gland continuously. So continuous secretion of cortisol will be there. If you are seeing this ultrasonographically, you will be seeing bilateral enlargement of adrenal gland. If you are seeing bilateral hyperplasia of adrenal gland, which is mostly suggestive of pituitary dependent Cushing. So next one is adrenal dependent Cushing. Kindly concentrate. This is also very important to diagnose the disease. So whenever adrenal gland tumor is there, so usually adrenal gland tumor either may be unilateral or bilateral, but unilateral adrenal gland tumors are very common. Here, unilateral adrenal gland tumor is there, which will secrete cortisol more. If the cortisol excess in turn gives negative feedback to the pituitary gland, so pituitary gland itself told the adrenal gland to stop the production of cortisol. So the contralateral adrenal gland stops the production of cortisol. So because of this continuous process, long term, the contralateral adrenal gland will be atrophied. Whereas the tumor mass present, no, that adrenal gland will be enlarged in size. So ultrasonographically, if you see, there will be a unilateral enlargement of adrenal gland and contralateral atrophied adrenal gland will be visualized. And this is iatrogenic Cushing's disease. So this is also important because of our external supplementation of steroids like prednisolone or some other steroidal injection for some other reasons. It will tell to the adrenal pituitary gland that I am already there in the circulation, no need to produce ACTH. And this will tell the adrenal gland to stop the production of cortisol. So long-term use of external steroids will lead to atrophy of both the adrenal glands. So bilateral atrophied or hypoplasia of adrenal gland will be visualized in case of iatrogenic Cushing's disease. So now, how will you diagnose the Cushing's disease? So diagnosis of Cushing's disease not depends upon the single factor. You should consider multiple factors to rule out the presence or absence of hyperadrenocortism or Cushing's disease. First and foremost, one is history, and after that, clinical signs. Then your hematology, serum biochemistry, urine analysis, then endocrine test, then supportive diagnosis by using the trichogram and skin histopathology, that is dermatopathology. Ultrasonography is very important differentiating test, and CT and MRI if available, then BP measurement. So these are all the list of diagnostic module. We should consider most of the modules so that we will arrive a conclusive evidence for the presence of disease. So history is concerned. The very important one is polyuria, because whenever bed wedding is there in the animal environment, it will disturb the sleep of animal as well as owner. So owner complaint is mainly polyuria. Then animal beauty lies on its hair. Everyone wants a nice hair coat of their pet. So whenever alopecia is there, they don't want to regret it. So they will immediately bring the animal to you and telling that the animal is having alopecia. Apart from that, pot belly and weakness, these are all the presenting history from the owner to the patient or dog affected with Cushing's disease. Clinical signs is concerned, the most common clinical signs are polyuria, polydipsia, polyphagia, and central opacity because of fat redistribution. Hepatomegaly is because of steroid excess, and panting because of muscle weakness, diaphragm muscle and abdominal muscle weakness, and muscle atrophy because of excess cortisol in the circulation, progressive bilateral alopecia, and systemic hypertension. These are all the most common clinical signs recorded in the animal. Then other clinical signs are hyperpigmentation, it because of excess melatonin, and calcinosis cutis is due to mineral alteration. There will be a calcium deposition in the skin and other areas of the body. Insulin resistant diabetes mellitus. In normal case of diabetes mellitus, there will be excess amount of glucose. It is above even 400. But in case of Cushing's disease, it is around 250, above 250. And it won't be responding to your insulin therapy. And if mass is there in the pituitary gland or adrenal gland, there may be chance of occurrence of mass occupying lesions or effects. Like pituitary gland is concerned neurological, anorexia, lethargy, altered behavior. Adrenal is concerned metastasis is very common because adrenal gland are more closer to the major vessels. That too, right adrenal gland is more closer to the caudal vena cava. So invasion of the tumor mass into the caudal vena cava as well as phrenico-abdominal vein is very common. This is the piece to recognize Cushing's disease in your clinical setting. As a practitioner, you have to remember the 7 P's to identify Cushing's disease in your clinical setting. One is animal presented with polydipsia, urea, phagia, part-bellied appearance, poor exercise tolerance, panting, and alopecia. In alopecia, you have to remember again 3 P's, that is papery thin skin, recurrent pyoderma, and hyperpigmentation, pigmentation. So these are all the P's you have to remember to catch the Cushing's disease. Clinical signs, there is a severe muscle wasting and abnormal body configuration. Because of muscle wasting, damage to the collagen fiber and elastin fiber, there will be a pot-bellied appearance. Here you can able to see pot-bellied appearance of the dogs and comedones in the ventral abdomen because of the blockage of sebaceous gland. Atrophied sebaceous gland cannot able to secrete more sebum, and there may be a blockage in the secretory path. It leads to comedone formation in the ventral abdomen. This is a comedones, and the calcinosis cutis. It looks like pyoderma, but if you are crushing the lesion, you will be getting a mineral deposit, calcium deposits. It's the typical calcinosis cutis observed in various areas of animal body. In the dorsal area of animal body, you will be seeing the calcium deposition, dry scaly lesion along with calcinosis cutis. Because of thin and fragile vessels and atrophied skin, there will be a phlebectasis and bruising of skin, thin abdominal vasculature. There is a prominent abdominal vessels will be visualized, and dry brittle hair and bruising, bilateral alopecia. Because of collagen fiber degeneration, there will be a muscle collagen wasting and delayed wound healing. Prominent vasculatures will be visualized. Bilateral alopecia and hyperpigmentation in the dog. Here, rough hair coat and flakes will be visualized. And this is mainly seen in iatrogenic Cushing because of topical application of steroid ointment without consulting a veterinarian for a long course of time leads to iatrogenic Cushing. Thin skin will be there in the affected animal. Here you see, and the hair follicle is logged and it cannot able to come out. So clogged hair follicle with this thin skin is typical in case of iatrogenic Cushing's disease. Hematology is concerned, you will be seeing stress leukogram, that is increased neutrophils, neutrophilia, monocytosis, and lymphopenia along with eosinopenia will be seen in stress leukogram. Serum biochemistry is concerned, there is elevated ALP level and consistent elevation of cholesterol and triglyceride level. It is because of altered lipid metabolism. And elevated blood glucose is due to gluconeogenesis because cortisol is involving in the gluconeogenic process, protein degeneration and lipolysis, which in turn cause excess amount of glucose in the animal body, and mild to moderate elevation of ALT and more accumulation of glycogen. Decreased bun will be there because of increased glomerular filtration rate, which enhanced urine excretion will lead to decreased bun level in serum biochemistry. Urine analysis shows low urine specific gravity because of frequent urination and higher glomerular filtration rate. Because of excess cortisol, there will be a chance of recurrent infection of urinary tract, bacteriuria, proteinuria, kidney damage, and glucoseuria will be there. And there will be a elevated blood pressure. Trichogram, as I said, it will be showed more of telogen hair follicle. Telogenation of hair follicle is very common in case of endocrine disorders, especially Cushing's disease, and reduction of the anagen hair will be noticed. Dermatopathology showed hyperkeratosis, so there won't be any hair growth, and atrophied epidermal layers and atrophied sebaceous gland will be visualized. Here you will be seeing the telogen hair, terminal telogen hair with wrinkled inner sheath, and this is the catagen hair fiber. This is atrophied sebaceous gland, and because of secondary bacterial infection, there will be a acute infiltration of inflammatory cells in the dermal area. These are all the dermatopathological changes will be visualized in case of Cushing's disease. And to differentiate Cushing's disease, whether it is ADH or PDH, we need to go with the screening test, then differentiating test. Screening test is concerned. There are 3: low-dose dexamethasone suppression test, urine cortisol creatinine ratio, and ACTH stimulation test. Among the 3, low-dose dexamethasone suppression test is very commonly used, very effective. It has high sensitivity and specificity. It will identify true positive cases, and it is easy to perform. Only disadvantage is it will take up to 8 hours time. Apart from the time duration, it is cost effective, easy to perform in your clinical setting with low cost. And accuracy also more, that is important. And ACTH stimulation test mainly used to diagnose iatrogenic Cushing's disease and treatment efficacy. This ACTH stimulation test is important. Differentiating test to rule out whether it is PDH or ADH. High dose dexamethasone suppression test is important. And the endogenous ACTH is very good, but ACTH is unstable. It is difficult to measure in your clinical setting. So it is not at all practically useful. That is measurement of endogenous ACTH. Ultrasound is best because every practitioner is having ultrasound in their unit. So it is important to do ultrasonography to differentiate whether it is PDH or ADH. Wherever possibility is there, you can perform CT and MRI further to differentiate the same. And among the endocrine test, low-dose dexamethasone test I told, the dose rate of low-dose dexamethasone test is you have to administer dexamethasone sodium at the dose rate of 0.01 mg or else 0.015 mg per kg, intravascular preferably, or else intramuscular. After, before giving the injection, you have to take blood sample, that is 0th hour blood collection. Immediately after you have to inject it, then you have to collect blood sample at 4th hour and 8th hour. The normal value of cortisol, you have after low-dose dexamethasone suppression test, we have to estimate the cortisol 0, 4 and 8 hours. Normal level of cortisol is 1 microgram per deciliter. If cortisol level reaches above 1 microgram per deciliter, either 1.2 or 1.4, it is suggestive of Cushing's disease. And urine cortisol and creatinine ratio measurement, it should be better to collect urine sample in owner's house premises so that you can avoid stress to the animal. If the value is less than 10, it indicates negative. If it is more than 10, it should be considered as positive, but retest should be done. ACTH stimulation test, you have to get ACTH injection. Actin prolongan injection is available commercially, which should be injected at the dose rate of 5 microgram per kg, intravascular or intramuscular. Intramuscular is preferable. Here, blood collection should be done before giving injection, 0th hour, then 1 hour. ACTH injection cost is 2,500 to 2,800 rupees. And if animal body weight is below 10 kg, you can give 125 microgram of ACTH as a total dose. And the body weight is above 10 kg, you can give 250 microgram of ACTH at the total dose. If the value is less than 550 nanomole per liter, it is normal. It is above, indicates hyperadenocortism. If the value is subnormal, which is suggestive of iatrogenic Cushing's disease. ACTH test can be used to measure treatment response and to identify iatrogenic Cushing. And for differentiating test, you can use either high-dose dexamethasone suppression test or urine cortisol creatine ratio combined with dexamethasone suppression test. But the best one is ultrasonography. If available, CT or MRI can be used. So this is low dose dexamethasone suppression test. Here you can see 4th hour and 8th hour we should see. This is 0 hour before injection, 4th hour and 8th hour. In the picture, lack of suppression. Lack of suppression indicates the case is positive for hyperadenocortism. Most common cause of hyperadenocortism is ADH, adrenal tumor likely. And if escape pattern is there, that is 4th hour, it can able to suppress. By 8th hour, again, it reaches above 1.4. It is definitely positive for PDH. That is more than 50% suppression on 4th hour. Subsequent increase in the 8th hour indicates PDH. So if suppression is typical, then this is very rare, unlikely to have hyperadenocortism. Other patterns like partial and inverse pattern necessitate further test, like imaging. So as I said, adrenal gland imaging is a very important differential test to rule out Cushing's disease. We have to use a 7.5 megahertz transducer, preferably linear transducer. The left adrenal gland is a peanut shape. In some small breeds, either dumbbell or biconcave disc shape. Medium and larger breeds, it is pancake or lawn chair shape. Left adrenal gland lies between the left kidney and the abdominal aorta, whereas right adrenal gland lies between the right kidney and caudal vena cava. The shape of right adrenal gland is always V. Sometimes it may be oval, and medium and larger breeds, it may be pancake shape, rarely. Left adrenal gland size varies, but right adrenal gland size shape mostly V shape. So this is the shape of adrenal gland taken in our clinical studies. So left adrenal gland, as I said, H shape or biconcave disc shape. Biconcave shape in the middle, phrenico-abdominal artery and vein will be crossing. Lawn chair shape, the left adrenal gland. Right adrenal gland is concerned 7 shape, V shape or oval shape will be there. So this is the anatomical landmark of left adrenal gland. As I said, left adrenal gland lies between the left kidney and the abdominal aorta here. The circled area is left adrenal gland. This is a biconcave disc shape left adrenal gland. You see laterally left kidney, medially abdominal aorta, cranially celiac and cranial mesenteric arteries. Caudally, you see this is the renal artery caudally. And this is the phrenico-abdominal artery above and below phrenico-abdominal vein, which can be visualized in ultrasonographically as such. So this is the position of right adrenal gland. As I said, it is oval shape or V shape. The circled, yellow circled one is right adrenal gland. So it is medial to the right kidney alongside with caudal vena cava. This is important. That's why right adrenal gland tumor metastasis is very common because it is alongside with the caudal vena cava. It is lies between the cranial pole of right kidney and the caudate lobe of liver. And ventral to this is phrenico-abdominal vein, right side. And the size of adrenal gland varies, depends upon the breed, size and body weight of the animal. Mostly we will measure caudal pole width of the adrenal gland. The normal range is 0.6 to 0.74 centimeter. Left adrenal gland is bit larger than the right adrenal gland. So adrenal gland image is concerned, this I told, this is the phrenico-abdominal artery crosses in the middle of the adrenal gland, left adrenal gland especially. This is the image of left adrenal gland. This is the measurement of left adrenal gland. And this is the phrenico-abdominal vein. This is arrowed white. Is the biconcave disc-shaped left adrenal gland. It is in the middle. So this is the aorta. Mostly the size of the adrenal gland varies. Always we will measure caudal pole thickness of the adrenal gland, which should be always compared with the aorta. As like CKD cases, we will measure left or right kidney to aorta ratio. Likewise, here we can measure adrenal gland to aorta ratio, which will give an accurate measurement than the single measurement of adrenal gland. So this is the V-shaped right adrenal gland. It is alongside with caudal vena cava. Same image with color Doppler. Various shapes of left adrenal gland. Mostly right adrenal gland V shape is very common or oval shape, but left adrenal gland shape will be varies, I told. So this is a lawn chair shape left adrenal gland. This is a flattened pancake shape left adrenal gland, and this is a biconcave disc shape left adrenal gland both. The biconcave disc shape adrenal gland only we will be visualizing phreneco-abdominal artery and vein. This is more of a vertical shape of left adrenal gland. So now comes to the pathological lesions. Adrenal gland tumors or adenomas. Tumors are very common. There will be a uniform enlargement of adrenal gland with isoechoic changes will be there in the ultrasonography. Here, bilateral enlargement of adrenal gland. This is adrenal cortical adenoma. This is the case presented to our clinic. You can see adrenal cortical tumor in the gross image. Same ultrasonographically seen in the marked yellow arrow. Adrenal gland hyperplasia. We have measured caudal pole thickness. We will be identifying the hyperplasia of adrenal gland. And here bilateral hyperplasia of right and left adrenal gland. Mostly this is because of PDH. And here uniformly enlarged adrenal gland, maybe adrenal gland hyperplasia. And this is the enlarged adrenal gland, indicates adrenal gland tumor. This is a dog presented to our clinic with history of Cushing's disease. The blood glucose level is 347 initially. We have did other tests and ultrasonography also done, which indicates bilateral enlargement of adrenal gland suggestive of PDH. And after ultrasonography, if available, we can do CT and MRI also, which will help to measure size and contour of pituitary and adrenal glands. And it will help to differentiate PDH and adrenal tumor, because adrenal tumors, as I told, it is more chances of metastasis, which can be able to identify through CT and MRI. Even ultrasonography also can be identified. Pituitary tumors and adrenal tumors can be coexist in some of the cases. So always we should not give a chance to identify coexisting diseases. So if CT, MRI available, better to do brain CT and brain MRI so that we can identify lesions of pituitary gland also. And this is important to decide treatment strategy. So this is a CT image of left adrenal gland. It is lies near the right kidney and caudal vena cava. This is the left adrenal gland near the left kidney and aorta. MRI image of pituitary tumor, which is having hyperechoic area. The lesion is filled in the third ventricle also. So it indicates the pituitary mass and which fills third ventricle. And here left and right, this is normal right adrenal, whereas here enlarged left adrenal gland in MRI. Next comes therapy, which is important. Once the disease is diagnosed, next we have to enter into the therapeutic protocol. Therapy is important to eliminate the source of either ACTH or cortisol, and to achieve a normal cortisol level, and to eliminate the clinical signs, to reduce complication and mortality, to make the animal to live quality life until the end of its journey. Without treatment, the survival term is less than 1 year. 1 year plus or minus 150 days. Without treatment, animal will survive. Types of therapy is concerned: surgical removal, radiotherapy, and pharmacotherapy. Surgical removal, either we can go for hypopysectomy if PDH is diagnosed, or adrenalectomy if adrenal gland tumors are diagnosed. Radiotherapy, either we can go for pituitary adenomas if identified, we can go for pituitary gland radiotherapy. Adrenal gland is concerned, if adrenal tumors are removed after surgery, you can go with radiotherapy to avoid further development of the disease. Surgical removal and radiotherapy is not widely available in our country. Mainly, we are relying on the pharmacotherapy. Pharmacotherapy is based on the drugs, why and what and where we are using. So, drugs targeting the adrenal gland, which is inhibiting the steroidogenesis. So, if we are choosing those drugs, steroidogenesis inhibitors, the examples are ketoconazole, mitropone, mitotin, and trilostan. And ACTH secretion inhibition drugs, cabergoline, glucocorticoid receptor binders, mifepristone, and other drugs like retinoic acid and seleglin. First, hypophyseectomy. Transsphenoidal approach is very common. We have to remove entire pituitary gland. The survival time is 700 days nearly. Remission will be there. Once you remove the pituitary gland, then we need to give replacement therapy because the TRH secretion won't be there. So we need to supplement thyroid hormone and glucocorticoid lifelong supplementation will be there. Antidiuretic hormone will be secreted from the pituitary gland. So no secretion of antidiuretic hormone. We need to supplement it by giving the desmopressin as a synthetic vasopressin analog. Complication of hypopexectomy is there may be a chance of perioperative death. Because of excess urine, there may be hypernatremia, cessation of tear production, diabetes insipidus, and recurrence also common. Adrenalectomy, if we identify the tumor unilaterally, you have to remove that adrenal gland. If we are seeing bilateral, then we need to remove bilateral. But left adrenal gland removal is a little easy. Right adrenal gland removal is tough because it is very close to the caudal vena cava. Laparoscopically, in human medicine, they are doing the adrenalectomy surgeries from 90s. The survival is nearly 700 days. There may be chance of hemorrhage, minor or severe hemorrhage. Apart from that, hypotension, tachycardia, even perioperative death is common. Pancreas lies very close to the adrenal gland, so chances of pancreatitis also common. If you identify metastasis, you should not proceed for the surgery. Other complications like thromboembolism also will be there. You have to take care of all the things. Radiotherapy not widely practiced in our country. Even then, the total dose for pituitary dependent hyperadenocortism is 36 to 48 Gray units. Adverse effects are pituitary hemorrhage and otitis media. Adrenal gland tumors are concerned. Only after surgery, this radiotherapy is indicated. This is the mechanism of drug intervention, what we are using for the treatment. So in this picture, just you see so that you can understand the concept of drugs, why and where and what you are using. IR drugs are not working also. So mitotin is concerned, it will be acting on the first step itself. It will be avoiding the conversion of cholesterol. So the cholesterol will be accumulating in the cell. More amount of cholesterol is there in the cell, which in turn leads to the stress to the endoplasmic reticulum, which in turn causes apoptosis of the cell. So that's why this mitotin is very important. Mitotin is adrenocorticolytic agent, anti-tumor drug. It will lyse the whole adrenal gland, cortex area of adrenal gland. And further, you see the trilostan, the next important drug, it should act on all the three places. It won't avoid the conversion so that it is again very much useful and effective. Ketoconazole, it is acting on so many places, but the efficacy is not that much and contraindications are more. And meteropone, not used in our country, European Union, they are using. It is also effective. It is avoiding the conversion of 11-deoxycortisol to cortisol. Next, we will see the same in little detailed manner. Ketoconazole, we all know it is antifungal agent. At the dose rate of 25 milligram per kg, it is acting as a steroidogenesis inhibitor. The total dose of the drug, as per the body weight, it should start from 400 to 1200 milligram. It should not exceed beyond 1200 milligram. It inhibits so many enzymes cytochrome P11A1, 1720, and cytochrome P11B1. Most of the animals are non-responders and more adverse effects are more. So we are not recommending ketoconazole for the treatment of Cushing's disease now. You can go for combination therapy instead. Levocorticonazole is maybe more effective, but it is under phase 3 clinical trial. Side effects are more hepatotoxicity, hypogonadism, and it requires gastric acidity for absorption. So you should not be given along with proton pump inhibitor. Mitropon, it is widely used in European Union. Potent selective inhibitor of cytochrome P11 and B1. It causes reduction in aldosterone and it adverse effects are hypoadrenocortisolism and GI adverse effects. Mitatin is very important drug. OPDDD, it is an adrenocorticolytic agent. It will cause adrenocortical necrosis and atrophy of both the adrenal glands. It acts by inhibiting the cytochrome 11A1 and 11B1 and also inhibit sterol O acyl transferase 1. That is the first step from cholesterol to next step conversion, cholesterol esterase. So more cholesterol accumulation inside the cell, as I said, and in turn causes cell apoptosis. The dose rate of mitatin is 50 to 75 milligram per kg for 7 days, 5 days, then alternate days for 40 days, then once weekly for 6 months. As per the need, you can give lifelong therapy. It should be given along with food. Because it is damaging the adrenal cortex, immediately there will be a depletion of glucocorticoids and mineralocorticoids. From third day, we need to supplement glucocorticoids at the dose rate of 2 mg per kg as cortisol acetate, mineralocorticoid at the dose rate of 0.0125 mg per kg, and salt as per need. You have to do serum measurement of the salt levels. And the survival time is nearly 1.5 years. The adverse effects of anorexia, weakness, lethargy, diarrhea, and this is a cytotoxic agent. So while prescribing to the patient, you should always tell it should be keep away from the children and the pregnant woman. And the efficacy and the loss of other sodium, potassium, and aldosterone level should be monitored, and urine cortisol to creatinine ratio should be measured. Trilostane, it is very effective competitive inhibitor of 3-beta hydroxysteroid dehydrogenase enzyme. It requires for the production of all the adrenal hormones. So it inhibits both cortisol and aldosterone. Also, it inhibits 11-beta hydroxylase. It is very much useful for PDH as well as adrenal tumor. It should be given along with food. Dose rate is 0.5 to 1 mg per kg. Some of the cases 2.8 mg per kg also should be given. The duration of action is 12 hours. So twice daily dose should be given. Within a week, you can see the reduction of polyuria, dyspsia, and phagia. Within months, skin lesions will be reduced. Similarly for mitotin also. Once the mitotin started, within a week, you can see the visible changes of urine production and all. Reduced urine production will be there. And within a month, the skin lesions will be improved. The survival time is nearly 800 days and the adverse effects are hypocortisolism. ACTH stimulation test can be used to monitor the trilostane efficacy. The mifepristone is the next drug. It is a glucocorticoid receptor blocker. Dose rate is 20 milligram per kg. Total dose is around 300 to 1200 milligram daily. Adverse effects of arthralgia, nausea, headache, peripheral edema, decreased blood potassium level. It is contraindicated in liver impairment patient because it is metabolized through liver. Cabergoline, it is a DA agonist. It decreases the ACTH secretion. It is helpful for controlling the PDH, but not all the cases. Retinoic acid, it acts by regulating the expression of pro-opiomelanocortin. This pro-opiomelanocortin is cleaved into multiple peptides to produce ACTH. Adverse reactions are there. Teratogenicity and mucocutaneous toxicity, defects of liver function and severe phototoxicity may be recorded, but it is very effective both in ADH and PDH cases. Seleglin, it is a selective irreversible monoamine oxidase B inhibitor. It increases dopamine in brain. Dopamine in turn inhibits the ACTH production. But if tumor is there or adenomas are there in the intermediate lobe, then only this is helpful. That's why it is not widely practiced. Apart from that, some of the newer drugs like osilodrostate, it is 11 beta hydroxylase inhibitor, promising for both PDH and ADH. Dark trials are now going on. Levocorticonosal, as I said, it is also under clinical trial. Pasireotide, it is available in human medicine, available in India. It is somatostropin analog, suppress ACTH secretion, effective in case of PDH. So now we are identifying adrenal tumor. One differential we should do, that is pheochromocytoma. Pheochromocytoma is a tumor of adrenal medulla. Adrenal tumor is because of adrenal cortical affection. So we need to differentiate it. So adrenal tumor is concerned, as I said, the margins are well clear marginated, isoechoic will be there, enlargement of the gland will be there. Whereas pheochromocytoma, it is not uniform enlargement, and there will be echogenicity changes in the gland ultrasonographically. You can see this is echogenicity changes and ununiform enlargement of adrenal gland. This is one of the differential. But for the confirmation, we need to go for histopathological evaluation. This is the case presented with enlargement of adrenal gland. We diagnose it as a pheochromocytoma in our clinic. Coming to the summary, we should not forget 7 P's in your clinical setting to rule out Cushing's disease. And the Cushing's disease is concerned recurrent urinary tract infection, pyoderma and pot-bellied appearance of the common clinical signs you will be seeing. Low-dose dexamethasone suppression test is the best screening test to diagnose Cushing's disease. Ultrasonography is the best differential test and mandatory to rule out Cushing's disease and to differentiate PDH with ADH. CT and MRI should be done if possible. It will add further clarity to your conclusion. If PDH is concerned, trilostane and retinoic acid is the best choice. AACT is concerned, adrenal tumors, mitatin and trilostane. Mitatin will work both for PDH and adrenal tumors. So take-home points. Commonly, the Cushing's disease encountered in older animals, more than 10 years of age. PDH is most common, 80 to 85% of the patients. Low-dose dexamethasone test is best screening test. ACTH stimulation test is best to evaluate the treatment efficacy and to diagnose Cushing's disease iatrogenic. Trilostane and mitotrone is the best drug available. We will be using mitotrone in India. Adrenalectomy is best if you identify adrenal tumor, but metastasis is very common. You have to rule out it. Cushing's disease due to iatrogenic is very easily reversible, but you have to taper the steroid which used, prednisolone. Sudden withdrawal should not be done. You have to withdraw it by tapering dose. Regular monitoring is crucial to identify or prevent the side effects like hypoadrenocortisolism, electrolyte imbalance, and other GI issues. Thank you for the opportunity given for IAVD and Drools partner. Thank you so much. And thank you for the VCRA Namakkal and Tanvas for permitting me to give this lecture. Thank you so much.
Thank you so much, Dr. Mohanambal, for that very, very enlightening session. Thank you very much. We at Drools recognize how important a role veterinarians play in ensuring the health and well-being of pets. As a brand, we are committed to pet nutrition and care, as well as have always prioritized supporting the veterinary community through knowledge sharing, collaboration, as well as initiatives that enhance pet standards. From educational workshops and seminars to providing access to high quality nutritional solutions, we strive to empower veterinarians with the right resources to make a difference. Our latest initiatives, I would say, namely, include Vet Thrive, which is where Drools funds veterinary equipment for veterinarians that have their own practice in order to upskill the veterinary clinic as well as provide a level of care that is not seen yet in India. Microscope, another program of ours, is a program for final year vet students. For them to understand the industry landscape. Students, as they are graduating from college, sometimes don't know the expanse of the industry, and it's always just practice. So there is a lot to contribute in the industry other than just clinical practice, and that is something that we as a company want to make known to the newer generation of vets coming into the industry. And lastly, we have our continuous education programs that help veterinarians upgrade their skills. We have it in collaboration with Tanuvas, in fact, where we have sessions that allow veterinarians to learn and get better at things that they are good at, and sometimes they may not necessarily have the skills to do. So we help veterinarians learn and get better at what they do to help the pets that they serve, as well as the industry as a whole. Now I would say it is time for our interactive question and answer session. So if you have any questions for Dr. Mohanambal, I would request you to please drop them in the chat box, and we will go ahead with the question and answer session. So there is one question, Doc, that I'm seeing in the chat session. Someone has asked how to differentiate between diabetes and Cushing syndrome by clinical signs alone.
Okay.
Yeah, I would like to
So diabetes is concerned, animal will be lean body weight. Cushing's disease is concerned, pot-bellied appearance will be there. This is a very, by seeing itself, we can able to tell. Even then, polydipsia, urea, phagia will be there by seeing the pot-bellied appearance. Pot-bellied appearance because of hepatomegaly and weakness of abdominal muscles.
One more thing to add to it. Diabetes, as we told, there will be lean in appearance. In Cushing's, it will be bulky. Second thing is this alopecia. Alopecia is more common in Cushing's, where in which in diabetes you will not come across this bilateral symmetrical alopecia. And telangiectasia, that is the prominent abdominal vessels, is more in Cushing's, whereas in diabetes you will not be getting that. And also thinning of skin is very typical to Cushing. So in that way you will be able to clinically make your diagnosis, but you have to go for a series of tests.
Yes. Another question we have in the box, Doc, is someone has asked what is the prognosis for Cushing's disease?
Okay, without treatment, animal will survive less than 1 year. With the treatment, it will live quality life. So without pain, animal will be living. Without showing the clinical signs, animal will be living. Even then, the survivability is very less. It is less than 2 years. But animal will be living without pain.
I think in the presentation it was mentioned nearly 700 days. With the treatment with both mitotane or trilostane, the dog's survival period has been compared, and approximately 700 days is the the prognosis of like the end of the dog or something like that. So it is around 700 days with treatment.
Another question that is there, Doc, is the pathology behind the pot-bellied appearance.
I already told. Pot-bellied appearance is because of fat redistribution and hepatomegaly, steroid-induced hepatomegaly, and weakness of abdominal muscles. All together will contribute the pot-belly appearance.
Another question that there is, Doc, is will there be a sudden weight loss in a patient suffering from Cushing's?
I don't think so. Sudden weight loss won't be there.
Mitotane tablets of humans, can it be used, or is there a veterinary alternative?
Yes. No. We are using human tablets, human mitotane tablets. 100 tablets, 500 mg bottle it is coming. The price is varies between 18,000 to 48,000.
Oh. Wow. Another question is someone's asking, Doc, will we also be able to note cystitis in a patient with Cushing's?
Yes, definitely. Because of cortisol-induced immunosuppression, there will be recurrent urinary tract infection and cystitis as well.
Brilliant. Another one is, how can the efficacy of trilostane be identified with the ACTH test?
So, if you are doing ACTH stimulation test, once ACTH injection is given, which will stimulate the pituitary to secrete more of cortisol. If treatment is ongoing, the level of estimation of cortisol should be done. So, we should compare before and after treatment or during the course of treatment. By seeing the level of cortisol, we can tell treatment efficacy.
And an LDST, LDDS will not work in that case, only an ACTH will work.
No, low dose dexamethasone test
Low dose
also.
dexamethasone also will work. Okay. Another last question, doc, that there is how to differentiate between PDI and Cushing's disease just by clinical science.
P
PDI.
PDI.
Can you
PDI.
please elaborate what PDI is? Person who has asked the question. Till then, I'll go ahead with the next question, doc. Is there any relationship with Cushing's and pseudo pregnancy?
No. So because from cholesterol, every hormone is producing. So, but the both are different entity.
And the last question is, have you noticed any side effects in trilostane and mitotane therapy?
Yeah, side effect I already mentioned in presentation itself. Every drug has its side effect. So mitatin is concerned if it damage the adrenal cortical region completely. So you need to supplement more of glucocorticoid and mineralocorticoids also because it is damaging more total of adrenal gland. Likewise, trilostane also.
Great. Thank you very much. There's another last question, doc.
Of the two drugs, mitotane and trilostane, the side effects with mitotane is more. So that is the reason people go in for trilostane.
Trilostane.
So yeah, that is the reason. And whenever you get a side effect, it is always likely that you should withdraw the treatment, wait for some time, and then you have to think about the alternatives. That is there.
And one of the last questions we have, doc, for you all is there any low-cost therapy for treating Cushing's?
Surgical excision, but the surgery is having complication. But compared to the drug usage, you can do surgery.
Someone is asking for trilostane cost price.
Trilostane is around $65 to $180. It comes around 12,000 to 18,000 around for 30 tablets of 30 mg.
Okay. There are some more questions. There's a question. A pot-belly appearance is a common cardinal sign in dog for roundworm. How do you differentiate from that?
So ultrasonography and age of the dog. It is most common in older age dogs, Cushing's disease. The worm infestation is very common in younger
dogs. Another question is when
other associated signs will be there. No, caries and ankylosome. I don't think it's relevant over here.
Yes. And question is, in the treatment aspect, which would be the best drug to start with?
Trilostane or mitotane?
Trilostane and mitotane. And another question is, when can you choose to use cabergoline?
If you are suspecting pituitary dependent hyperadrenocortisolism, you can choose cabergoline.
Choose cabergoline. Okay. Thank you, Dr. Mohanambal again and Dr. Sumati as well for answering the questions. To conclude, I would like to invite Dr. Venkateshwaran, the Vice President of the IAVD, to please deliver the vote of thanks.
Good evening, everyone. I'm Venkateshwaran, Vice President of IAVD.
Good evening, sir.
First of all, Dr. Mohanambal, you have done a wonderful lecture. And before concluding, I invite you all for the ICVD 4 program in Pune from 13th to 15th of April. I request you all to come and attend the ICVD 4 program. And before that, we have a workshop which is specially for cytology and dermatopathology. Now, because this is being conducted for the first time in India by a foreign speaker, Dr. Sonia, who is going to do the entire work. So that is a limited participation only 30 are allowed. And I request you all, whoever is interested in cytology and histopathology, to register yourself immediately into the our workshop program, which is to be conducted in Hyatt Regency in Pune on 12th and 13th of June. And I sincerely thank Dr. Ivanka, Anisha, and the entire Drools team for organizing such a wonderful program. I thank Dr. Sumati for giving the introduction. Not only that, supporting Dr. Mohanambal in the questionnaire session. And again, I profusely thank Drools and Dr. Mohanambal for giving a wonderful lecture for all the dermatologists in India. Thanks, one and all.
Thank you very much, sir. Before we wrap up, I would like to remind everyone to kindly please fill out the Google link that I have reshared again in the comment section to receive your certificates for this webinar. Again, we have a few upcoming seminars over the next few months that we will be doing again in collaboration with the IAVD. I have put it up onto the screen. Of course, we will share the brochures with you. We will allow for registrations again, but this is just so you have an idea of the courses that we will be talking about, the topics that we will be touching over the next month. Thank you again to the IAVD. Thank you to Dr. Mohanambal, Dr. Sumati, and Dr. Venkateshwaran, and thank you to the Drools team as well. Thank you to everyone who joined us on a Saturday. I know despite the India-Pakistan match today, it was a brilliant turnout. We had 250 people that joined the meeting. Thank you very, very much for making time for us today. And we look forward to seeing you at all our future sessions. Thank you, everyone, and have a good evening.
My friends and I, we talk about everything under the sun. So how can we leave out discussing something as important as our pets and their diets?
Always remember to check the back of the pack when it comes to buying food for your pets.
Make sure that you're feeding only real and clean ingredients.
It is 100% real chicken.
No byproducts
or fillers.
All natural, all healthy ingredients.
It gives them the best of both, taste and nutrition.
Drools.
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 Drools. Feed real.
Feed clean.